Hello, everybody. Can you hear me? Great. My name is Lynn Tanoue. I'm director of the lung cancer screening and pulmonary nodule program here at Yale. And I think Roy Herbst was supposed to come to introduce me, but it's like waiting for Godot. So I think we'll just get started. I know a lot of you in the audience, but I don't know a lot of you, so pleased to meet you. I was asked to give an overview of the screening program as it's functioning right now, and I want to introduce Frank Detterbeck, who is co-director, and Polly Sather, who is the APR and who really runs this, because they are really instrumental in making this happen. And my only disclosure is I'm a member of the ABIM Pulmonary Board. So what I want to do is give you a really quick overview about lung cancer screening, the evidence base, the benefits and risks of screening, and what it takes to have a successful program. And then I'll give you some information about our screening program to date. And I wanted to point out that this is a joint effort. Frank and I started this program 3+ years ago. Polly Sather really is the feet on the ground, and she makes this happen day to day. And Curtis, Demetrius Dykes, and Jonathan Killam from Diagnostic Imaging have been instrumental in standardizing our approach to reading the CT scans. And Ben Toll, who is not at Yale any longer, he went to the Medical University of South Carolina, headed up the smoking cessation program, which is obviously really an important piece of this. And other people have taken that over now. But I wanted to give those people credit because that's how we got off the ground. So I shouldn't need to tell this group that lung cancer is the leading cause of cancer death in the United States. In men, that has been the case since 1950 something, and in women since about 1986. So these are the mortality rates from the American Cancer Society for the different tumors going back to 1930 when this information first started being gathered. And the red lines are death rates from cancer. And what becomes very clear is that lung cancer causes more cancer death than several of the next leading cancers combined: breast, prostate, and colorectal. So it is an enormous problem. And in contrast to the other three most common solid tumors, we haven't seen huge advances in improving survivorship. So if you look back over the past 40 years at breast, colon, and prostate, you can see that the 5-year survival rates have all significantly improved. All these little asterisks are that there's been significant improvement. Lung cancer also has a little star, and so there have been substantial, significant gains made in 5-year survival, but this is a really good example of a small number can be a significant result, although we'll take 18% compared to 12%. And when you look at why this is the case, there are many reasons behind the fact that the 5-year survival rate in lung cancer is so low. But I think part of it is that the other solid tumors have really enjoyed better research funding, and this is NCI research funding per death per site, and you can see that breast has gotten a lot more money than lung. In fact, so has colon and prostate, and I don't begrudge all of you out there your dollars in funding, but I think lung has been, hi Roy, rather underfunded. And so better research leads to better treatments. I think Smilo Cancer Center and the TOP program is a really good example of application of all this cutting edge science to the care of patients. But one could also argue that all of these other three solid tumors have a well-established, well-accepted, embedded in clinical practice means of early detection. And while we could probably have a very robust debate about the efficacy of mammography and colonoscopy and PSA testing, there's no question that those interventions are widely practiced and have led to early detection. And up until now, we have lacked that important intervention for lung cancer. So that brings me to the last day of 2013, and on that day, the USPSTF changed their recommendation for lung cancer screening with this landmark recommendation for annual screening for lung cancer with low-dose CT in adults ages 55 to 80 who have a 30-pack year smoking history and currently smoke or have quit within the past 15 years. This completely changed the recommendation. I don't know why they waited to the last day of 2013. Because the data for this really came out in 2011, and the majority of the evidence supporting lung cancer screening with low-dose CT relates to the National Lung Screening Trial. This was a United States trial. It enrolled over 50,000 subjects ages 55 to 74. To get in, you had to have smoked at least 30-pack years, and you had to have quit within the past 15 years or be currently smoking, hence the USPSTF mirroring of that. And this study randomized subjects to annual chest X-ray or low-dose CT as the screening intervention. The arm that was missing was the no intervention arm, which actually was standard of practice. There is an ongoing study called the PLCO that you all probably are quite familiar with. And in the PLCO, the comparison for lung cancer screening is no intervention, no screening versus chest X-ray. So that the study design randomized patients to either chest X-ray or low-dose CT. There were 26,000 subjects in each arm. The study was powered to demonstrate a 20% relative reduction in mortality in the low-dose CT arm. The lung cancer risk in this population with heavy smoking and somewhat older over the 6 years of the follow-up was 2 to 3%. As it turned out, the important results are here, and what you can see is that low-dose CT detected more lung cancers than plain chest X-ray. But the important finding is that there were fewer lung cancer deaths, so there was a decrease in mortality in the low-dose CT arm. There have been plenty of studies previously demonstrating that you can find more cancers if you do a higher tech study like a CT compared to a chest X-ray, but until this study, there really had never been a demonstration of a benefit with reduction of mortality, and that is the gold standard measure of a successful screen. And then the other important thing is that the majority of the screen-detected lung cancers were stage 1, and so there was this shift of stage towards lower stage disease where with surgery or surgery plus adjuvant therapy, the 5-year survival rates are much better than the 12 to 18% overall that we're still seeing. The PLCO data, which were released at around the same time, demonstrated that there was no difference between screening with chest X-ray and no screening. And so by extrapolation, the screening with low-dose CT has improvement in mortality compared to no screening. That really wasn't part of the study design, but this study cost $250 million. And it would have cost another $125 million to enroll another 26,000 patients to randomize to a no-screen arm. And so the conclusion of the NLST is that screening with low-dose CT reduces mortality from lung cancer. And on the strength of this randomized trial, Medicare agreed a year after the USPSTF recommendation to cover annual screenings for lung cancer for older Americans with long histories of heavy smoking. And actually the CMS guideline indicates ages 55 to 77 and the 30-pack year smoking history. And so the USPSTF recommendation actually included a slightly older group up to age 80. The NLST was only to age 74 and CMS landed at 77, which I assume is an average of those two numbers. So that we've spent a long time preparing to screen for lung cancer. We've been talking about it for decades. The information relating to low-dose CT as an imaging modality for screening really started back in the late 1990s. And we had, between the 2011 publication of the NLST and the Medicare announcement 3 years later, to figure out how to do this properly. And it's very clear that screening for lung cancer really involves more than a test. Because the test is a complicated one and the patients have a lot of comorbidities. And so Peter Mazzone from the Cleveland Clinic spearheaded this ACCP and ATS policy statement, and I think, Frank, you are an author on this. And this is a very long, very dense, really well-written document outlining all the components that are necessary. Who are you going to offer lung cancer screening to? How often and how long do you screen? How do you perform that low-dose CT? What is the definition of a nodule? There should be structured reporting to avoid acting on findings that are incidental and unimportant. This requires the development of management algorithms for the predominant finding of the low-dose CTs, which is lung nodules. You have to have a smoking cessation program. Smoking cessation as an intervention is much more powerful than any screening program you could devise. You have to educate patients and providers, and we need to collect data to prove that this is actually all worth it, because the price tag on this, if every person eligible in the United States got screened tomorrow, is about $8 billion. This is my summation of that very dense article, and I don't expect you to read it, but I put this up here just to illustrate that it really isn't just a scan. None of the screenings should just be about doing a test. There really should be an informed discussion with the patient. And I think to do this well, there has to be institutional programmatic commitment. There has to be an evidence-based evaluation of risk and benefit for individual patients related to screening, because you have to consider the issues of cost. So the benefit when you talk to patients about screening is pretty clear. It's that 20% relative reduction in lung cancer mortality that the NLST demonstrated. But I think it's important to recognize that this benefit is not evenly distributed across even the NLST population. And so this is a sub-analysis that was published a couple of years later, and using validated risk assessment models, of which there are now more than 4 easily accessible publicly. This group, headed by Dr. Kowalczyk, divided the NLST population into 5 quintiles of risk, from lowest down here to highest. And this is the number of deaths. And what you can see is the majority of the benefit is really concentrated in the higher quintiles of risk, which makes sense. But what they use to define those quintiles are really readily available risk stratification models that generally aren't used commonly in clinical practice. And then if you go one step even further and say, well, what about everybody else? Why don't we just screen everyone? We don't have such strict boundaries around screening for other cancers. Michael Gould and Peter Bach did this really nice analysis that was published in the Annals. And they looked at people who might be typical participants in the NLST, people who were minimally eligible, and then people who are high risk, and then people who really shouldn't really be thinking about screening. And Michael chose Sequoia Hospital because he was driving down I-5 in California, and Sequoia Hospital was advertising to be screened for lung cancer for anybody. And the number needed to treat in the NLST to save one life was 300. If you took a typical participant, so somebody kind of in the middle, that number became 256. If you only screened really high-risk people, and this one is a 70-year-old current smoker, 110 pack years, you have to screen many fewer patients to save that life. And then if you screen everybody in California, you need to screen 35,000 people. And so all of this factors into whether or not this kind of test is cost-effective. And the cost-effective analysis that was published in the New England Journal, I think just last year, shows that screening for lung cancer in that designated population is as cost-effective as mammography, basically. But if you start wandering outside the designated population, the cost-effectiveness is going to fall. So the balance of the seesaw is, what are the risks associated with lung cancer screening, because there are risks. And the ones that are clearly identifiable is that the false positive rate is really high. In the NLST, about 25% of the subjects had a new nodule every year that a scan was done. 96% of those nodules are not cancers, and that has borne out in all of our screening programs. All of those nodules generate more imaging, and every image is a dose of radiation in a population that's already at risk. And we know that lung cancer is one of the cancers where cumulative radiation in adulthood matters in terms of increasing risk. And so now we're radiating a population that's already at risk. And then all of those nodules inevitably will increase invasive diagnostic procedures, needle biopsies, bronchoscopies, even surgeries. Those become, quote, necessary now because the suspicion for cancer is present. But you could say if you never had the screen and you didn't have the false positive finding, you would never have had the intervention. And the Dante's study results from Europe that were just released were a little concerning that in a community hospital setting, the rate of these sorts of procedures was actually higher than in NLST, which was predominantly done in tertiary centers. And so these are the components that we felt were necessary for a lung cancer screening program because of the risks primarily. You need to have your low-dose CTs read in a standardized fashion. When we started out, there was no algorithm for this, but the American College of Radiology is now recommending that we use lung rads, which is a parallel effort to the way mammography is read. You really need a nodule program to deal with all the positive findings that fall out of the studies. The low-dose CTs need to be done low dose, otherwise they are radiating in excess of what's necessary. You need a multidisciplinary group to deal with the nodules in the same way that we have a multidisciplinary group for lung cancer. And there really should be standardization of the approach to these findings, which means you have to have algorithms built for your assessment program. There obviously should be a smoking cessation program closely linked or embedded within the screening program. It is mandated that you sit with the patients and have a decision support visit so that they can understand the pros and cons of having the screening. And Medicare actually has made that necessary. And clearly we aren't all the way there yet, and we have a lot to learn about this population, the risks related to screening, what benefit we can gain. And there is also a mandate from CMS that every patient who is screened in an approved program be entered in a national registry. So it takes a lot of people to do this, and this is the group that participated in one of our free lung cancer screening events. We held 4 over the year of 2014. There's Frank, there's Polly, there's Ben Toll. There were people there from the pulmonary function lab because we decided to include spirometry. This is Mario, or Marco, I forget, he's an Italian research person, and Steve Baldessari, who's one of our pulmonary fellows, because we're trying to study as we go, the CT text, so on and so on. It actually takes a lot of people to make this program happen. So I'm not going to walk through this that way. Oops. So this is the workflow for our screening program. The patient is referred either by themselves or by another provider. Their eligibility is determined in the diagnostic imaging department with a decision support tool for the provider ordering the study. Assuming that they meet that eligibility requirement, which is again the USPSTF, CMS, and LST criteria, they meet POLI and have a decision support visit. This takes about half an hour. There are various decision support tools that are now available. We developed our own, but there's one available from the American Thoracic Society, another one for the VA. It's a very informative session for the patient who can opt at that point to have the study or not to have the study. And I think of the 7 years or so that Polly's done since we revamped our program, one actually opted out after hearing the risks and benefits. Assuming they go, that they want to have the screen done that same day, they have a low-dose CT. We actually look at all the results, but the results go back to the ordering provider, who is typically the primary care provider for the patient. If there is one or more abnormal findings, we make sure that the ordering provider is aware of that. And a lot of these nodules end up being presented currently at our tumor board. We don't currently have a separate nodule board. We are also getting referrals from other people's screening programs so that when there are positive findings, patients who were willing to have their screen done at another institution often want to come to Yale to have that evaluation performed. Polly also goes through with the patients this tool that is a risk predictive tool developed out of the PLCO and validated actually in NLST. And you can get this online and you plug in your patient's information and it spits out for you the probability of lung cancer in 6 years. So for this imaginary patient that I plugged in, their risk of lung cancer in 6 years is 5.6%. That's about double NLST. And so this is a patient that you might really think hard about screening. We had developed several years ago with the help of Gitan Michaud, who was at that time on pulmonary faculty, is now at NYU, and Paul Gillard, who is currently a fourth-year Yale medical student. These are iPads, and our educational tool is in iPad format, and the patient can scroll through this independently, ask questions if they want. It looks like this. It's written, for 8th grade language. And they also go through our decision support tool to really understand the motivation of the patient for their wanting to be screened, and to make sure that they have a chance to ask questions about the nuances of screening. We developed this before the ATS and the VA came out with theirs. Ours is very much meant to be an interactive in-person. The VA and ATS ones are really designed for the patient to do on their own. So we looked at the first 100 patients after we had 100 patients, and this happened in about the end of 2014. And what we saw was that of that first 100, 12 of the patients actually did not meet the USPSTF or NLST criteria. These were people who by and large were worried, or their doctors were worried. And some of them we screened because the risk was high enough, and some of them we tried to talk off the cliff and send out the door, although then all the onus is on me to say, I hope you don't have a lung cancer because I just told you not to be screened. We had a very high nodule finding rate. Out of that 100, there was 1 lung cancer. And what we realized pretty quickly was that there was this incredibly high rate of non-lung findings. Besides emphysema and ILD, we were finding coronary calcifications, adrenal masses, renal cysts, liver abnormalities, aortic aneurysms, and it became clear that we had to ask whose responsibility is this, because at that time we were ordering the scan and providing all the follow-up care. And this was taking a huge amount of time, and since we were not the patient's primary providers, it was probably not the best pathway for those patients to be getting those results and then trying to decide on a plan. We did start at that time our lung cancer screening biorepository, which is embedded in our lung cancer biorepository, and we enrolled 70 patients. And so we shut the program down briefly after the Medicare approval came out, and all of those structural requirements were made quite clear. And we reopened in September of last year. One big thing that came along was the lung RADS was vetted and published, and while it is not a requirement that you use this reading schema, we are using that for our reports. We also developed at the same time structured reporting for all of the incidental findings, and we did that with our radiology partners. So before this, I already showed you this data. And since the fall of 2015, when we reopened, we screened 73 patients. All of these patients have met the USPSTF requirements. Our nodule rate is still really high, even though we are using the lung RADS threshold of 4 to 6 millimeters compared to anything goes. And it just shows the nodule rate is really high in this smoking population. And we just had our first cancer of that 73. Patient actually had surgery just a few days ago. It turns out he had 2 adenocarcinomas in the same lobe. The higher stage 1 is a stage 2. Right. And then what's really helped is that we have instituted this structured reading for the incidental non-nodule findings. The most common is coronary artery calcification, and pre-2015, 70% of these patients who are older and who smoke had coronary artery calcifications, and our radiologists pretty much were reading out everybody who had any, got it, called out. And that, more than anything, was incredibly alarming to the patients who are now able to see their reports. And what our radiologists did was to really try to quantify by segment counting the amount of coronary artery calcification. This is kind of an issue across the country, and I think we're probably on the leading edge of this. And using a much more structured approach where I think you have to have 5 out of 9 segments be calcified to call it out on the scan. Now we've got that number down to 1/3. Still very prevalent though. And then you can see, as you compare aortic aneurysm, thyroid nodules, adrenal nodules, that the rate that we're calling these out on the report so that it's a do something about this finding that we found by accident is lower. And we have a nodule program. This has actually really been part of our top program for a very long time. And so that there is a structure for us to walk the patient through a nodule evaluation. We actually have standardized approaches to nodules that we developed for the thoracic oncology program a number of years ago before screening that we are using. in this setting. And then I just want to touch on the what about all those other people who don't fit into the strict criteria, because I think this will be a concern down the road. It is a concern already, and I get asked this question all the time. What about all those other people who have cancer risk? 45 million Americans current smokers, 90 million Americans ever smokers, women who never smoked, and then all the patients who've had exposure to carcinogens or who have long-standing lung injury that puts them at higher risk. And we really don't have a paradigm for them, and for at least the time being, we are trying to stick to the patients for whom we know the screening is of benefit. But I showed you this model already. This is the model, again, from Tamamagi that was developed from the PLCO. This is a patient who's 64, high school education, has COPD, a personal history of cancer, a family history of lung cancer, a parent or something, is Caucasian, smoked 2 packs a day for 26 years, but stopped smoking 22 years ago. And so on the basis of the fact that the last cigarette was more than 15 years ago, this patient actually does not fall in the criteria that is accepted now for lung cancer screening. But I already told you that his risk for lung cancer over the next 6 years is 5.6%. That exceeds the average risk of the population with the NLST. And for this patient, we don't have an easy answer. We will counsel those patients if they come to see us. And obviously, we're not at the end of the road. We're really just at the beginning, and I hope that people in this audience might be interested in the moving forward, because CT scan is a really blunt tool, and we should develop much better tools for predicting cancer risk than an imaging study. And this is going to involve, I think, using the patient's own materials to develop easily applicable tools in easily accessible tissues like buccal mucosa, nasal epithelium, breath, or blood. And hopefully, as we move along, we will collect data on these patients that will allow us to proceed that way. Any questions? Frank, did you have anything to add? Holly?